mechanisms that I already showed you. Let's use the presence of the HER2 gene, the protein on the cell surface to get the antibody in the tissue and let the payload do the work. And that's the DESTINY-Breast04 study that most of you must know already, so I won't bother you long with that. It was presented by Shan Modi last year at ASCO. And this is now the study in hormone receptor positives, HER2 negatives, but HER2 low. Don't get confused. HER2 negative, clinically HER2 negative, so not 3+ and not amplified, but having some kind of HER2 expression. And in those patients, it was required that they had at least 1 or 2 prior lines of chemotherapy in a metastatic setting. So again, focusing on patients that are quite heavily pre-treated already. And then randomization was treatments of physician's choice chemotherapy. So exactly that situation that seems to be quite popular among us doctors, where we give the chemotherapy, and now the question is, can we be better than that by giving TDXD? And this is just to show you the baseline characteristics. Most of the patients had liver metastasis, 70%, 30% had lung metastasis. Some patients with brain metastasis, of course, not as many as the HER2 positives. And here you see the previous number of chemotherapies, and there was quite a large number, about 40%, that received 2 or more chemotherapies already in the metastatic setting. So again, it's a quite heavily treated population. And regardless, progression-free survival could be extended with a hazard ratio of 0.5. Some of you might be disappointed, but again, it's heavily pre-treated. So a progression-free survival time of 5 months with the control arm, that's the standard. Very short, very rapid progression in these advanced therapy lines. And nevertheless, this could be extended to 10 months. But even more important is the 6 months difference in overall survival that was also statistically significant. And now, that's a good message for the patients. You have the CDK4/6 inhibitors, 12 months improvement of overall survival. Now, there's a second substance in a later therapy line, and you're adding another 6 months of overall survival benefit in average to the treatment sequences. That was not also only true for the hormone receptor positives, but also for the triple negatives that had some kind of HER2 expression. Although it was a small subset with only 60 patients in that study, progression-free survival could be extended again to the hazard ratio of about 0.5, and the overall survival could also be extended by about 10 months to the hazard ratio of about 0.5. I like to remember 0.5, there's 0.46, 0.48, that's better than 0.5, some people say, but I can remember that always 0.5. 0.5, that's pretty good. It's doubling the median PFS time, and it's doubling the median overall survival time. The forest plots of these studies are incredibly boring, because all subgroups always show this benefit, because these substances obviously seem to be very effective. If you see a subgroup like that, that's only due to small sample size with a little bit more than 50 patients in other races than white or Asian. And again, this one, in my opinion, for us clinicians, the most important chart, because it shows the response and something very similar. And think of the patients, they're 3rd line, 4th line, or even 5th line, and you give a drug that has, in most of the patients, a shrinking of the tumor. That's very satisfying and motivating to see in clinical practice that you have, after some other failed therapies, another substance, so the tumor can shrink. Everything comes at a cost, of course, so let's focus a little bit of time on the side effects. And when I started working in the 1990s, I was responsible for the patients doing high-dose chemotherapy and autologous stem cell transplantation. We don't do that anymore. It works so well. But it came with lots of side effects and lots of vomiting. And even after the high-dose chemotherapy, before the HT3 antagonists and the NK1, there was also lots of vomiting in the hospital, 30%, 40% of patients. And then all these super active substances were introduced, the 5-HT3, NK1, together with cortisol. And now it was in breast cancer at least that maybe 1 out of 20 patients would vomit, or 1 out of 25 patients would vomit. And that was since 2005. So now think of doctors that worked for 15 years or 18 years in that field in Germany, they wouldn't have seen vomiting. And now vomiting is back. So they think it's super bad. I say, yeah, I don't want my patients to vomit, but it's not that bad. It's not as bad as it was before we had the medication. But I just want to encourage you, and you see so many patients here, so I'm not going to tell you how to take care of vomiting, you know that. But just with the TDXD, if you felt comfortable that not many patients are vomiting, now you really have to take care of this again. And this means making sure the patients understand so the patients really understand it's important, because once they are vomiting, there will be more vomiting in the next session just because they're scared, they're anxious, and that fosters more vomiting. So just take care of that. I'm sure you know how to do that. And in that trial, and it doesn't seem a lot, but it's something that really needs to be understood. There were 3 cases where patients died of this interstitial lung disease. And there was a higher percentage in the early development program of TDXD, and that the number is so low is the consequence of doctors being very strict how they react to when they see an ILD on the PET scan, on the high-resolution PET scan, or when a patient shows up with respiratory symptoms. And to be honest, I kind of feel more comfortable in the setting that you are in, because I assume you have all the specialties here in-house, the radiologists and everybody, so you don't have a network of doctors you have to rely on, they're all in-house. So you can maybe go over to them and talk to them and say, hey, we have a new substance, and you have to know this and this and that about the substance, because where we had problems to get to in our hospital is that, let's say, a patient comes on a Friday evening or on a Saturday night at 2 a.m. and has respiratory symptoms. Any doctor that sees that patient has to understand this is going to do steroid therapy as soon as possible. And we had cases where that didn't happen. A patient would show up on a Tuesday evening, and the surgeon who had a bad day would see that patient in the emergency room and thinks, now that patient is looking quite okay compared to the 20 other patients that I've seen today that do much worse. But that doesn't mean it will stay like that. It will change within 24 hours or 48 hours, and then you would be happy to know the PET scan to see how the development is. You would want to have the comparison of the PET scan from 2 days ago. So if you miss that, you'll be sorry not to have that. And if you don't start the corticosteroid therapy, and we don't talk about the steroid therapy for weeks, it's just for the time for the ILDs there for 2 weeks, in most of the cases, so there won't be like steroid side effects in the long run. Why not start it? Why the patient did look good, so that's why it started. Yeah, but it wouldn't have damaged the patient, and it would maybe prevent a bad course of the ILD 2 days later. So it's very important to understand that the whole team, again, I want to tell you about how to treat the vomiting. And we do the 3 substances, dexamethasone, 5-HT3 and NK1. They're now in one pill, the NK1 and HT, to add olanzapine. But our women like to be alert when they leave the hospital. They live in the countryside, so they don't like to be sleepy. But it helps, and the doctors that I know that use it, it calms the woman down, and it makes a little bit of less vomiting. So have to decide on a patient-to-patient basis. So the pneumonitis, that's important. If it's discovered in the CAT scan without any symptoms, it's considered grade 1. If there's additional symptoms that are moderate, it's considered grade 2. But if the respiratory symptoms affect the daily activities of the patient or need oxygen, it's grade 3. So there's some kind of subjectivity to this grading thing. But the first reaction is, don't give another infusion of the TDXD at no cost, so don't do that. And ILD shows up, for example, in a CAT scan that is done for disease assessment. You cannot continue the treatment until that is resolved. It has to be completely resolved before you restart the treatment. You can try the same dose or reduce it at the same dose, or can reduce the dose by 1 dose level. But if it's grade 2, it's already a harsh consequence. Discontinue permanently. Because we would not want to take the risk that a symptomatic ILD gets worse or occurs again and then leads to the death of the patient. I have some slide later. It's 8% of the patients, so that's the case, that are grade 2 or grade 3 ILD. So 1 in 12 patients that have started on the TDXD will not finish that. But the studies, the Kaplan-Meier curves, they don't care. It's the intention to treat, even including all of these patients who treatment needs to be stopped. The difference in the patient population is still that big. So But it's important not to use steroids, like 1 milligram per kilogram body weight of prednisone for at least 14 days, or if the resolution of the ILD takes longer for longer. But if it's grade 3, so there's a relevant impact on daily activities, it has to be done IV for 3 days at 500 or 1,000 milligrams. And that's what the guideline says. We all always use 1,000 milligrams. You know, why use 500 and then high cortisol dose for 3 days? And then you can reduce it to the oral 1 milligram question. But isn't that a pity if I have to stop the treatment? I mean, remember, it's only 8%, so it's not a large number of patients. With many other chemotherapies, you have to do dose reductions or therapies are stopped because of side effects. So that's nothing unusual that treatments are permanently discontinued. But doctors get a little bit more brave. I wouldn't encourage that you don't do it yet, but other doctors already start. If the ILD resolved super quickly and the symptoms were only like a little bit, like I feel it's hard to go up the stairs at the end of the day, you know, what is symptomatic? You know, there's some kind of interpretation in there. But I wouldn't recommend it for now. I mean, like a little bit more of experience in my hospital. That's what I would want to see before we do that. So grade 2, permanently discontinue. Grade 3, permanently discontinue. Do the cortisol therapy, watch the patient closely, and even with grade 1, the ILD has to be done away before you restart the treatment. And that's the data from the Destiny Breast 3 study and the Destiny Breast 4 study, where you can see that grade 2 and grade 3 is about 8% of the patients, 1 in 12 about, where the treatment has to be stopped permanently. Okay, just to be fair, there's other ADCs, like the sacituzumab govitecan, and that's also in hormone receptor positive HER2 negatives and in triple negatives, and that's the hormone receptor positive study. Randomized study, it's a big study, and this patient population was rather really advanced therapy line. Needed at least 2 previous chemotherapies, so more than in the Destiny Breast 4 study, but not more than 4 lines of therapy, so it's a little bit later on in the therapy line. And again, treatments of physician's choice was compared with sacituzumab govitecan, the TROP2 ADC, and again, an overall survival benefit. And because they really spoiled me there. And then they looked at all these trials. But for the patients, it's really nice. 12 months CDK4/6, 6 months with the TXT, another 3 months with the sacituzumab govitecan. Maybe in some years from now we will get there so that we can get metastatic breast cancer patients die from something else than metastatic breast cancer. Not there yet with the effect. Maybe 2 more years would be needed to see an effect, but now to have like 3 trials and 3 substances that can extend overall survival, it's really nice to see. Of course, that was all implemented in the guidelines here. With trastuzumab deruxtecan and sacituzumab govitecan, and it kind of changed a little bit the way how I prescribe medications, because now you give a CDK4/6 inhibitor, and then the next substance that has an overall survival benefit down the therapy lines is TDXT. So as per label right now, and we see maybe it might change in another trial that's coming out. So we accept that as a basis for treating triple-negative breast cancers with TDXT. To be fair, a much larger trial in a randomized way is the ASCEND study, focusing on triple negatives with the sacituzumab govitecan, but that's in much more advanced therapy lines, 2 or more chemotherapies, different, so 1 more therapy line at least than in the Destiny Breast 4 study, but now we have a larger sample size. So what do we do as doctors? We have a small study subset of triple negatives, HER2-low expressing in an earlier therapy line, and a larger study in a later therapy line. So it's up to you what to do, but we do the same as in hormone receptor positives. We usually sequence the sacituzumab govitecan after the TDXT. But both treatment options are good because progression-free survival was improved by the sacituzumab govitecan, and also the overall survival was improved for these triple-negative breast cancer patients as well. So it shouldn't be missed in the treatment sequences of triple-negative breast cancer patients. All right, last few slides. What are the next steps in HER2-low? And I always make the joke, I already know the next results of the next presentation, because every single presentation that you see about the ADCs is pretty much works independent of presentation. Sacituzumab govitecan works high TROP2, low TROP2, independent of. Then works independent of HER2, and then the next one again independent, and at ASCO was even DDC works independent of histology, so that's like independent. It's just joking, so don't take this to practice. But it's true to some extent. So obviously we want to know, do we actually need the HER2 expression at all? Or could it be that very similar here in Italy, because in France it's not approved, the vaccine, so it's an albumin-bound, paclitaxel albumin-bound.
No, it's not available, but it's labeled.
Sure. But the albumin is thought to carry the paclitaxel much more efficiently into the tissue. And we've seen in triple negatives double as high PCR rates in the neoadjuvant setting, comparing the solvent paclitaxel compared to the albumin-bound paclitaxel. So this is not the chemotherapy in the tissue, it's an old concept from the 1990s. The purpose, nothing can travel so good between the blood and the tissue, and now they help the chemotherapy to get better into the tissue. So that's for sure, in my opinion, one of the effects that helps conveying the efficacy of ADCs, not only the targeted delivery of the payload. So why not look for populations where there's even less HER2 present in the tissue, much less. And so the Destiny Breast 06 study is basically going into a direction where they leave away the chemotherapy requirement. So they don't require the chemotherapy anymore before giving the TDXD. And they add this population down here, HER2 immunohistochemistry more than 0, so there has to be some kind of little expression, and less than 1. And now think of the changes in antibodies over the last 30 years, because both Darko and Ventana, new anti-HER2 antibodies for the immune system, there's now cases where you see a little bit of expression that with the old HER test from 20 years ago would have been absolutely negative. So now you include cases that have a little bit of expression with these super sensitive antibodies and less than 1. And this will add another 26% to that patient population that could be possibly treated with a TDXD, with an ADC. So that's pretty much it. I'm not sure whether there's time for a case, but I can make that quite quick.
Yes.
So that's a patient, lovely lady. She's now 68, and she was diagnosed with hormone receptor-positive breast cancer a long time ago, 2008. And it was a not so big tumor, high estrogen receptor expression, T67%. With the surgery of the right breast, she got a radiotherapy, and then we tried an adjuvant endocrine treatment with tamoxifen. But I know this lady, she's very strong opinion, so she came back after a few weeks, put me the tablets on the table and said, I don't like it, I won't take it. So that's okay, you cannot force somebody. And it was good for actually 8 years, so she did local recurrence. Came back with quite some tumors in the breast, almost 4 centimeters and between 2 and 3 centimeters, so quite large. Again, hormone receptor positive, HER2 negative, and she got an adjuvant chemotherapy with epirubicin, cyclophosphamide, and paclitaxel. And then again, we tried endocrine treatment. Again, after a few weeks, she came back, took the tablets and said, I don't like this one. They make too many side effects, so she didn't want to do that. Unfortunately, she got another local recurrence, and at that time she got a mastectomy, and as you can see down here, the darkness score at that time was 2+ negative. So she had that, what we would now call HER2 low. And at that time, of course, the TDXD was only known from the study programs, it's not approved yet, and she was R1, so the tumor was reaching so far at the muscle into the axilla, it was very hard to actually get it off in between that area. So it was a resection of 1, there was tumor tissue left, and by that she would be locally advanced in the metastatic palliative category. We started the treatment with palbociclib, and under the palbociclib it was okay for 6 months, but then she developed skin metastasis in front of the sternum and lymph node progression. And the skin metastasis actually looked very much like there were some skin metastasis that you could touch, like nodules, but also treat. Once you have skin metastasis with the inflammatory component all across the chest wall, so it's not a nice situation to have. cannot see that here so well, but I'll just have another picture where you can see it. So after that, after these 6 months, because the patient actually admitted one more time, yeah, maybe I didn't take the tablets as regularly as I should. So we thought it's a good idea, maybe try the abemaciclib, it's a different side effect profile, so change the anti-aneurysm treatment. So we give her abemaciclib, and that was good for another 7 months. So that was a good decision to do. And then after the next progression, we put her on the capecitabine. So just to fulfill this requirement, TDXT was available now. Just to fulfill this requirement as quickly as possible, we didn't look for PI3 kinase mutation. We didn't try the everolimus. She didn't like the side effects. So just let's try to get to an infusion therapy that we know is effective as quickly as possible. So we put her on the capecitabine, which did not work so well. It just took 3 months for the skin metastasis and the inflammatory component to see to be growing. And that's what it looked like. So you can see these nodules everywhere. And in between, that's not good here on the projector, but in between would be all this inflammatory skin parts, where you would have like this inflammatory component between the skin metastasis, knowing that this would spread quickly. So we started the trastuzumab deruxtecan this year in March, and it was nice to see already, and I think you can see that here on the projector. This on the left side is before of the day of the infusion, of the first infusion, and on the right side, it's only after 3 weeks. So you can see that the therapy effect was seen pretty much immediately, and that pretty much carried on up to now, where you would still see this scar tissue. For some reason it looks blue here, it's not blue, it's red. But the inflammatory component is gone, and it stayed stable like that for the last 6 months, which I consider a very nice success in inflammatory breast cancer treatment. That's pretty much it. I'm not very good at these summary slides. I'm not good at them. If I was unable to tell you the content of my presentation, now it's too late. So thank you very much for your attention, and thank you very much for dedicating some time to it.
First question, very illustrative and very interesting way of presentation, very nice. Now we will start the discussion, and I think we have
I go back over there because I feel I'm hiding it.
I don't want to hide. I think we have a very good data with CDXD, and it's very amazing. What about your expectation for the future? I know we have ongoing trials in the upfront situation, in the adjuvant, and in the neoadjuvant. Especially I'm talking about the neoadjuvant, the testing level.
Sure. This is chemotherapy or this is antibody therapy, so the therapy management is very similar. If you would want me to bet on the study outcome of this Invest 11, the neoadjuvant study, of course I would bet on the TDXD, because it has been such a tremendous improvement for all the trials. It has a ratio 0.33 in the HER2 positives. I would be super surprised if there wouldn't be a big difference in the neoadjuvant setting there.
Yeah, we still don't have hands on TDX1, but you are telling me that we have a lot of systems in comparing to chemotherapy.
No, it's not worse than chemotherapy, not at all. I would rather think it's a little bit less than chemotherapy,
yes.
But it's not like the TDM1s. I mean, the TDM1 was the first ADC that had good efficacy, was very tolerable, but the efficacy is much less than with the TDXD. Yeah. Now we have a very effective antibody drug conjugate, and now, of course, we have more toxicity. I would say a little bit less than chemotherapy, but more than the idea of that we will go into the future with the toxicity of TDM1. We see other ones, there's other anti-HER2 ADCs that have also very distinctive side effect profiles. So we have to learn about this linker. We have to learn how this linker, or which linker design is associated with what efficacy, which linker design leads to what toxicity, and what payload in combination with linker leads to whatever. And that's not well known. We don't see the studies. And I, as a doctor, see they're super effective, so I'm happy I have them. But what you're just mentioning is exactly what everybody's thinking about these days. Why do they work? What can we do differently to make it more work? Why do these ADCs have those side effects and others? There's not much known about that. So that's definitely the research that we have to do the next few years.
do you think the breast cancer will have a lot of ADCs? We will have more and more antibody drug conjugate for breast cancer. We know the results from immunotherapy in the breast cancer are disappointing for breast cancer. So we have targeted therapy, we have chemotherapy, still chemotherapy is going well. Now we have the combination ADC. Do you expect more and more in that area?
That's an easy answer. I truly believe that the ADC as a platform, as a technology, will change the way how we do the trials over the next few years. I think there's two more platforms that might be the radionuclides. We already see in prostate cancer big success, so that's a good platform for moving into the future. And the last one might be the proteins, which are where any kind of protein can be integrated based on a technology platform. But for the radionuclides, we don't know yet. For the proteins, we don't know yet. They're super efficient platforms. For the ADCs, already now, clear answer, yes. This will change the way how we do the future trials. And there's lots of more ADCs coming from all kinds of companies these days. Yeah.
We have
Shifting between CD4.
Yeah. So I'm one of the directors of a study group called TRIO. This is Translational Research in Oncology. So we're responsible for Paloma 1, Paloma 2. So our hearts bled not to see overall survival benefit with the Paloma 2 trial. I'm saying that because it's not that we don't like the drug, but we don't give that one anymore because it doesn't have an overall survival benefit. It could be the study wasn't good. Nobody knows, but it could be the medication is not that good. We will never know. So not taking the risk, what remains is ribociclib and abemaciclib. These are the two ones that remain that are considered very effective, both of them. And of course, if a patient doesn't like one, we did the same with the aromatase inhibitors some 10, 15 years ago. You could switch to the other one. And sometimes women like that one better, and sometimes women like the other one better. So I don't have a preference there. We start many patients on the ribociclib now. That was different in the pandemic, where everybody was staying at home. So diarrhea was not such a big problem with the abemaciclib because the toilet is just there at home. But now with most women going back to work and doing lots of stuff outside again, many of them don't like the diarrhea anymore. So now it's more ribociclib. In the pandemic was a little bit more abemaciclib. But I couldn't answer your question, what is my preference. Those are good drugs. Okay. It's left in our hearts. There's very effective substance, but unfortunately no overall survival benefit.
About the particular question of HER2-low, they are still under the category of triple negative or luminal, and they are treated under this category in the guidelines. And when we try to enter this new drugs for HER2-low, after we start with the guidelines for other urinary or triple negative, or in the future they will be line.
Yeah. So that's what our categories. And from a biological standpoint, these are the categories. They're biological, but that's not important for us treating patients. We want to know, does the drug work? And then we give it to the patient. Biology is important for scientists, so we're doctors, right? So HER2-low is regardless of the subtype. It's triple negative, HER2 positive, hormone receptor positive, HER2 negative, and there is many trials ongoing right now to move all the ADCs as early as possible. There's lots of trials going on. Destiny Breast 06 hopefully will report soon that we can give it without chemotherapy in hormone receptor positives, and even learning about this ultra-low subtype, we will be shifting that again to maybe another patient category, but always get it as early as possible. Right now, in hormone receptor positives, you need one chemotherapy before to fulfill the label, to fulfill the study. That might go away. The same is with the TROP2 antibodies. They also are now being tested in earlier therapy lines for both. I think Daiichi has a TROP2 antibody. They're doing studies in the first-line setting. The cyclophosphamide is also tested in the first-line setting. And there's more companies coming with ADCs And it will come, but right now it's for the more advanced therapy lines, but it will move to the early lines, I think, rather quickly.
We here in Egypt have trastuzumab, labatinib, and pertuzumab, but in the metastatic situation, we are allowed to use two drugs, Herceptin and labatinib. In the public sector, I'm talking about. We are doing something off-label if my patient is giving chemotherapy with Herceptin and for 6 cycles chemotherapy and they continue maintenance for Herceptin. So after that, if the patient progresses, I may rechange with another type of chemotherapy and on shift to labatinib, and I will use a lot of time to save time and save months for my patient. This is off-label. What do you think about this? I know that's outside the guidelines.
Off-label use for what? For the labatinib?
No, I don't change. I know the guidelines. If you give Herceptin injected with chemotherapy and your patient progresses whatever, you will get chemo or TDXT now. We don't do this because we don't have all of the options. So I will rechange with chemotherapy again.
Yeah.
With the Herceptin.
Yeah. So one therapy principle that's very important for HER2 positive, and this goes back to understanding HER2 positive disease. It's a genetic background. You have amplification, and this amplification is driving the cancer. It's one of the most aggressive oncogenes out there, HER2, and it's a genetic alteration. It's in most of the cases, in almost all cases, a gene amplification, and that's given from the mother cell to the daughter cell to the daughter cell to the daughter cell. So in clinical trials, there are these trials called treatment beyond progression, which refers to anti-HER treatment. Regardless of progression, anti-HER2 treatment has to be covered continuously. So never stop treating anti-HER2.
Yes.
Regardless, let it be trastuzumab, let it be labatinib, you can change all the rest.
Yes.
But anti-HER2 treatment, regardless of progression, should be continued at all times, because that's the genetic background of the disease.
Yeah.
And this doesn't go away.
Yeah.
It's being multiplied from cell multiplication to cell multiplication, and the HER2 amplification will stay. And we know from these treatment beyond progression trials, referring to the trastuzumab mainly,
Yeah.
it has to be covered at all times, has to be continued at all
Change the
times.
chemotherapy.
Yes. Don't stop the trastuzumab, don't stop the trastuzumab or whatever anti-HER2. And even in hormone receptor positives, there's good data with regard to the combination with the endocrine treatment. I even remember there was one study called Electra that was also running here in Egypt pretty okay, with letrozole and trastuzumab, Electra trial. I might be wrong, but I think there was some very good studies that's here from Egypt at that time.
Maybe because of Amy.
Yeah, I don't know.
Yes.
And the era of biosimilar, do you prefer to start initial therapy if I have the two, the drugs, the brand and the biosimilar one, if I have the chance to have both, what do you prefer, to start initial treatment by the brand or just biosimilar in maintenance phase, and the possibility of interchangeability between both?
No, there's one study, it's like one study opened my eyes, and you have to read the whole story. And that's the approval trials for the Samsung biosimilar. It's Ontruzant. That's a Samsung biosimilar. And these guys had problem because they had 10% higher PCR rate with the biosimilar. And that's not good, because now the authorities would say, well, that might be different substance. And they also had better event-free survival, hazard ratio 0.65 or something like that. At that time was called SB3. So if you want to look literature, it's called SB3, the biosimilar. And then they learned, or they proved, that the reference Herceptin, they said there was bad Herceptin. So the manufacturing process would be not good, so the Herceptin had almost no ADCC. And then investigations started. And the authorities said, no, everything was super. All quality measures for the production of the Herceptin were just fine. And that's where I learned, talking to many people producing antibodies, that antibody production has a lot of variability. And we've seen that with the trastuzumab from Genentech. So there seems to be quite some variability, leading sometimes to a batch that has 10% lower PCR rate, which is a bad message for us doctors, because I didn't know that before. But which one has this effect, I don't know. This could happen to a biosimilar, the same thing could happen to production of a biosimilar. So I don't have a preference between biosimilar or the other one, but this story shows that even the Genentech, Roche, trastuzumab sometimes has bad quality. Maybe next time the other Herceptin or biosimilar has bad quality, I don't know. I find it quite scary that I learned that, I find it quite scary, but the regulation authorities assure me everything is okay.
Yes. Thank you.
This discussion with you, Professor Fajron, and we really appreciate your effort to come here to London, and we really need to repeat it again, and we really thank AstraZeneca for their support and their effort to sponsor this. And really, we are very thankful to you for your effort and hope to see you again. Thank you. Thank you.
يلا يا جماعة وجمال يلا ماشي يا جماعة ماشي يا جماعة ثواني كده ثواني تمام تمام